On NCLEX, cardiac meds are everywhere. Beta blockers, ACE inhibitors, get them confused and you're picking the wrong answer. In real life, that means giving the wrong damn med. So we're locking this in right now. Here's your song. Then we're doing 15 NCLEX questions. No guessing by the end. All right. Beta blockers end in Olol, ACE inhibitors end in Pril. Here's how to never mix them up again.
Beta blockers end in Olol. Beta blockers end in Olol. Olol means beta blocker. Slows the heart, drops pressure down. Pulse below 60, hold that dose. Cold turkey causes rebound. Bradycardia and fatigue. Asthma patients, that's a no. Hides low blood sugar, key fact. That's what you gotta know. Beta blockers end in Olol. Slow it down, lower the wall. ACE inhibitors end in Pril. Keep that pressure standing still. Know your drugs, know your side effects too. That's how you pass NCLEX. Yeah, you're gonna get through. Olol for beta, Pril for ACE. Cardiac meds, let's go. You've got this. Let's ace this place. Pril means ACE inhibitor. Helps the failing heart to heal. Dry cough, that side effect one. Angioedema, stop for real. Potassium rises, watch those labs. Pregnancy, absolute no. First dose, have your patient sit. Protects the kidneys, now you know. Beta blockers end in Olol. Slow it down, lower the wall. ACE inhibitors end in Pril. Keep that pressure standing still. Check the pulse, hold it, fits low. 60, dry cough from ACE. Gotta go, switch it. Don't stop, beta blockers cold. Taper, pregnancy and ACE, no. Beta blockers end in Olol. You've got this. End in Olol.
That's your mnemonic. Now, let's see if it actually stuck. 15 NCLEX-style questions. Read each one. Think before you answer. I'll walk you through the reasoning. A nurse is preparing to administer metoprolol succinate 50 milligrams PO to a client with hypertension. Before administering this medication, which assessment is most important? A. Blood glucose level? B. Apical pulse and blood pressure? C. Respiratory rate and oxygen saturation? D. Serum potassium level? B. Metoprolol is a beta-1 selective blocker that decreases heart rate and blood pressure. The apical pulse and BP must be assessed before each dose. Hold if HR less than 60 beats per minute or BP is outside parameters. Client teaching time. And yes, this is select all that apply. Take a breath. A nurse is educating a client newly prescribed atenolol for hypertension. Which instructions should the nurse include? Select all that apply. A. Rise slowly from sitting or lying to prevent dizziness. B. Stop taking this medication if you feel your heart beating slowly. C. Do not skip doses or stop this medication abruptly. D. Monitor your blood pressure and heart rate at home. E. This medication may make it harder to feel symptoms of low blood sugar. The answers are A, C, D, and E, not B. Never tell your patient to just stop a beta blocker. Abrupt discontinuation can trigger rebound hypertension, angina, even an MI. They call their provider. They do not make that call themselves. Everything else? Teach it? The hypoglycemia I'm asking? Especially critical in diabetic patients. Lock that in. Classic. This one shows up on the NCLEX more than your professor's favorite PowerPoint slide. A client is prescribed lisinopril 10 milligrams by mouth daily. 3 weeks later, they call reporting a persistent dry cough. What is the nurse's best response? A. The cough means the medication is working. Continue taking it. B. Stop the medication immediately and go to the emergency room. C. This is a known side effect of lisinopril. Let's notify your provider, and an alternative may be considered. D. Take an over-the-counter cough suppressant and continue the medication. C. This is a known side effect. ACE inhibitors block bradykinin breakdown. Bradykinin builds up, irritates the airway, and you get that dry, persistent cough. It's not dangerous, but it's annoying enough that patients stop the medication on their own. And that's the problem. The move? Notify the provider. ARBs are the go-to alternative. Same blood pressure control. No cough. This one is not a drill. Swelling of the lips and tongue. You have seconds to make the right call. A client taking lisinopril calls the clinic reporting sudden swelling of the lips and tongue that started 30 minutes ago. The client denies shortness of breath, but sounds anxious. What is the nurse's priority action? A. Ask the client if they have taken any new medications recently. B. Instruct the client to take diphenhydramine and monitor symptoms. C. Direct the client to call 911 immediately. D. Advise the client to hold the next dose and come to the clinic tomorrow. C. Call 911 right now. This is angioedema, a rare but life-threatening side effect of ACE inhibitors. That airway can close fast. You do not have time to ask about their medication list. You do not have time for Benadryl. You definitely do not have time for come in tomorrow. Airway, breathing, circulation, 911. That is the answer. This client is going to the cath lab. 4 meds on the list. Which ones do you clarify? Read carefully. A 58-year-old male with hypertension and type 2 diabetes is admitted for elective cardiac catheterization. His medications include carvedilol, lisinopril, metformin, and aspirin 81 milligrams. Pre-procedure labs show creatinine 1.9, GFR 38, potassium 5.4. Which medications require clarification before administration this morning? A. Carvedilol. B. Lisinopril. C. Metformin. D. Aspirin, 81 milligrams. E. No medications require clarification. B and C. Lisinopril and metformin. Lisinopril, potassium is already 5.4, and the kidneys are struggling with a creatinine of 1.9. Adding an ACE inhibitor before contrast dye? Clarify that. Metformin. Contrast dye plus metformin is an acute kidney injury risk. Most protocols hold metformin 24 to 48 hours before and after contrast. Carvedilol. Vitals are stable. No hold needed. Aspirin? That keeps vessels open during a cath. You want it on board. B and C. Clarify before you give. A nurse reviews labs for a client on lisinopril 10 milligrams daily and spironolactone 25 milligrams daily for heart failure. Potassium is 6.1 milliequivalents per liter. Sodium 138, creatinine 1.3. Which action should the nurse take first? A. Administer both medications as scheduled. B. Hold lisinopril only and notify the provider. C. Hold both medications and notify the provider immediately. D. Encourage the client to eat potassium-rich foods to balance levels. C. Hold both. Now. Lisinopril is an ACE inhibitor. It raises potassium. Spironolactone is a potassium-sparing diuretic. It also raises potassium. Combined with a K plus of 6.1, that is a cardiac arrhythmia waiting to happen. You do not give either one. You do not split the difference and hold one. You hold both and you call immediately. And D, potassium-rich foods when potassium is already 6.1? That's cute. Carvedilol and heart failure. Know why it works? Not just that it works. A nurse is administering carvedilol to a client with chronic heart failure. Which statement best describes why carvedilol is used in heart failure management? A. It increases heart rate to improve cardiac output. B. It blocks both alpha-1 and beta receptors, reducing cardiac workload and peripheral resistance. C. It directly dilates coronary arteries to improve myocardial perfusion. D. It promotes sodium and water excretion to reduce preload. B. Carvedilol is a non-selective beta blocker, but it also blocks alpha-1 receptors. That dual action is the key. Beta blockade slows the heart and reduces oxygen demand. Alpha-1 blockade dilates peripheral vessels, dropping the resistance the heart pumps against. Less workload, better output over time. It is not a diuretic. That is D. It does not dilate coronary arteries. That is C. And it absolutely does not increase heart rate. That is the opposite of what it does. B. Lock it in. A nurse is caring for a client with hypertension who takes losartan 50 milligrams daily, an ARB. Which statements about losartan are accurate? Select all that apply. A. Losartan works by blocking angiotensin II receptors, preventing vasoconstriction. B. Losartan commonly causes a persistent dry cough. C. Losartan is contraindicated in pregnancy. D. The nurse should monitor potassium and renal function periodically. E. Losartan can be safely combined with ACE inhibitors for additive blood pressure control. A, C, and D, not B and not E. B is the classic NCLEX trap. Dry cough is the ACE inhibitor side effect. Losartan blocks the angiotensin II receptor directly, so bradykinin never builds up. No cough, but it is still contraindicated in pregnancy, same as ACE inhibitors. Both classes are off the table. And yes, monitor potassium and kidney function. Both classes affect the RAAS system. E is the dangerous one. Combining an ACE inhibitor and an ARB doubles the kidney risk with minimal added benefit. A, C, and D. A nurse is caring for a client with a history of asthma admitted for new onset atrial fibrillation with rapid ventricular response. The provider orders metoprolol tartrate 5 mg IV for rate control. Which action is most appropriate? A. Administer as ordered. Metoprolol is cardioselective and generally safe in asthma. B. Hold the medication and contact the provider to discuss the asthma history before administering. C. Substitute propranolol. It is more effective for atrial fibrillation. D. Administer half the dose and monitor respiratory status. B. Hold it and call. Yes, metoprolol is cardioselective. It primarily targets beta-1 receptors in the heart, but generally safe is not the same as safe without a conversation. In active or severe asthma, even cardioselective beta blockers can trigger bronchospasm. This is IV. It hits fast. You need that provider conversation before it goes in. And C, propranolol is non-selective. It blocks beta-2 in the lungs too. That is worse for asthma, not better. B, clarify first. A client taking ramipril 5 mg daily for heart failure has a potassium of 5.8 milliequivalents per liter and a creatinine of 2.4 with a baseline of 1.0. Which finding is most concerning and should be reported immediately? A, potassium of 5.8. B, creatinine of 2.4 with a baseline of 1.0. C, both findings are equally concerning and should be reported together. D, neither finding is significant for a client on ramipril. C, both. And this is exactly where students get tripped up, trying to pick just one. A potassium of 5.8 is hyperkalemia, cardiac risk. A creatinine of 2.4 when baseline is 1.0? That is more than double. That is acute kidney injury developing in real time. Together, on ramipril, an ACE inhibitor, this picture is clear. The kidneys are struggling. The potassium is rising because the kidneys can't clear it. Both. Report both right now. A nurse is teaching a pregnant client who asks if she can continue taking losartan for blood pressure control during pregnancy. What is the nurse's best response? A, yes, losartan is safe throughout pregnancy. B, losartan is safe in the first trimester but should be discontinued after that. C, losartan is contraindicated during pregnancy and your provider needs to prescribe an alternative. D, it depends on your blood pressure readings. Continue it only if needed. C, contraindicated. Full stop. Not first trimester safe. Not, it depends. Losartan and all ARBs and ACE inhibitors cause fetal renal damage, reduced amniotic fluid, and fetal death in the second and third trimesters. The provider needs to switch her to a pregnancy-safe antihypertensive. It's like labetalol or nifedipine. This is not a bedside judgment call. The answer is C, and it is not debatable. Bowtie question. This is next-gen NCLEX territory. Read the full picture before you pick anything. A 67-year-old male with heart failure, hypertension, and type 2 diabetes. On metoprolol succinate, lisinopril, furosemide, and insulin glargine. Vitals, B, P 88/54. Heart rate 52. Client reports dizziness, extreme fatigue, and cold hands and feet. Labs. Potassium, 3.1, creatinine, 1.8, blood glucose, 74. Select two actions, identify the condition, and select two parameters to monitor. Actions, hold metoprolol and lisinopril, and notify the provider, administer IV normal saline bolus per standing order. The condition, symptomatic hypotension and bradycardia secondary to medication effect. Monitor blood pressure and heart rate trends and serum potassium and creatinine. Here's why. A BP of 88/54 is hypotensive with symptoms. Heart rate 52 with cold extremities. The beta blocker is overcorrecting. Creatinine at 1.8 is climbing. Potassium at 3.1 is dropping from the furosemide. You hold the medications causing the problem. You fill the tank. You watch the trends. That is the answer. A nurse receives orders for a newly admitted client. Metoprolol tartrate 25 mg by mouth twice daily, lisinopril 5 mg daily, furosemide 20 mg daily, and potassium chloride 20 milliequivalents daily. Current vitals, BP 142/88, heart rate 58, potassium 3.8. Which medication should the nurse clarify before administering? A, lisinopril 5 mg. B, metoprolol tartrate 25 mg. C, furosemide 20 mg. D, potassium chloride 20 milliequivalents. B, metoprolol. Heart rate 58 is at the threshold. Most facility protocols hold beta blockers for a heart rate below 60. 58 is below 60. No hold parameter is written in this order. That means you call. You do not guess. You do not assume the provider is fine with it. You make a 2-minute phone call before giving a medication that can slow an already borderline heart further. The other meds? Lisinopril at 142/88. Appropriate. Furosemide at 20 milligrams. Low dose, no contraindication. Potassium at 3.8. Low normal, proactive supplement with a diuretic on board. But metoprolol at heart rate 58, clarify first. A nurse reviews the medication list of a client who takes lisinopril 10 milligrams daily. The client reports starting several new substances recently. Which substances could cause a dangerous interaction? Select all that apply. A. Ibuprofen 400 milligrams by mouth as needed for headaches. B. Potassium supplements purchased over the counter. C. A salt substitute containing potassium chloride. D. Antacids containing calcium carbonate. E. Trimethoprim sulfamethoxazole, Bactrim, for a UTI. A, B, C, and E. Everything except the antacid. Here's the pattern. ACE inhibitors raise potassium. Anything else that raises potassium becomes dangerous on top of it. Potassium supplements, obvious. Salt substitutes, sneaky. Patients think they are making a healthy swap without realizing the substitute is potassium chloride. Ask specifically about salt substitutes. Bactrim, trimethoprim blocks renal potassium excretion, just like a potassium-sparing diuretic. Combined with lisinopril, hyperkalemia risk is real. Ibuprofen, NSAIDs reduce blood flow to the kidneys, blunt the ACE inhibitor, and increase acute kidney injury risk. D, the antacid, no significant interaction. But A, B, C, E, all of them. Know the pattern. Anything that raises potassium or stresses the kidneys is a red flag with an ACE inhibitor. A 71-year-old female with heart failure and hypertension on carvedilol, enalapril, and furosemide. 4 weekly clinic visits show blood pressure dropping from 148/90 to 102/60. Heart rate dropping from 82 to 56. Weight dropping 9 pounds in 4 weeks. Creatinine rising from 1.1 to 2.1. Potassium rising from 4.0 to 5.6. Week 4, severe dizziness, fatigue, decreased urine output. For each week 4 finding, does it require immediate intervention, continued monitoring, or no action? Every single finding at week 4 requires immediate intervention. Every one. BP 102/60, asymptomatic hypotension. Hold carvedilol and enalapril. Heart rate 56. Bradycardia at threshold with symptoms. Creatinine 2.1, nearly double her baseline. That is acute kidney injury in progress. Potassium 5.6. Hyperkalemia with cardiac risk on enalapril. And the 9-pound weight loss in 4 weeks. That is the root cause. The furosemide pulled too much too fast. The tank is empty. And when the tank is empty, blood pressure drops, kidneys suffer, potassium climbs, and the heart slows down. The medications that were helping are now hurting. This is why you trend. Week 1 looked like improvement. Week 4 is a crisis. The data told the story. You just had to read it. That's Cardiac Meds. 15 questions. Real clinical pressure, and you made it through. Here's what you lock in before you leave. Beta blockers. Check the heart rate and blood pressure before you give. Below 60? Hold it. Call first. ACE inhibitors. Watch the potassium. Watch the kidneys. Dry cough is expected. Lip and tongue swelling? That's 911. Not tomorrow, now. The song gave you the hook. The questions gave you the pressure. Now, go use both. If this helped, subscribe. More mnemonics, more NCLEX pressure. More of this. I'm Stacy, and this is Scrubs and Chaos. Let's go!